Hello, everyone, and welcome back to The Daily Apple. I am here with today's guest, Dr. Jenn Simmons. She's a board-certified breast surgeon, integrative oncologist, one of the most outspoken voices, challenging the convention breast cancer playbook. After nearly 2 decades in traditional surgical oncology, Dr. Simmons made the bold pivot away from the standard model of care and realized it wasn't fully serving women's long-term health. She now focuses on addressing why cancer develops in the first place, looking at hormones, metabolism, inflammation, lifestyle, and root cause drivers that are often ignored, and really honing in on appropriate screening that supports safety, comfort, respect, and dignity for women. She's the author of A Smart Woman's Guide to Breast Cancer, which I would recommend taking a look at if you have breast or if you know anybody that does. She hosts a popular podcast by Keeping Abreast, correct?
Yeah.
And works with women around the world who want informed, empowered choices. And this conversation's about breast cancer, yes, but also prevention, hormone health, medical dogma, and
we're going to cover it all, right?
Yeah.
Like if you're a woman and you're concerned about women's health, you're concerned about your health, you're concerned about breast health because breast health is health, then we're going to cover you today. We've got you.
Yeah. Well, it's great information to put out there. I've seen this all the time where, women are like, hey, where do I start? What's the right thing? Do I even be doing mammograms? So yeah, I'm really excited about the topic, and it's just, I appreciate you making time. So thank you for being here.
It's my pleasure. So happy to be here. So happy that Tara introduced us.
Yeah.
Yeah.
So yeah, just start with, I love the intro in your book. I'd recommend it for people because I love, when it started, it's like, okay, this is a fun read too, so it's enjoyable, but then it's a lot of meaty, good, solid information and not much wasted time at all. I think it's really pretty awesome. But tell me about, you were 20 years in surgical oncology, right?
Yep. Yeah.
And you started.
So do you want to know how a surgeon walks away from it all and turns on a dime?
Yeah. I get asked that a lot.
Well,
yeah. I like to hear your story.
So I think that, my call to the breast cancer space was nothing more than I was just living within the confines of what my heredity dictated, in that I come from a breast cancer family. And I don't actually remember a time in my life where I didn't know about breast cancer. It's absolutely part of the fabric, the thread of the tapestry of my family. So growing up, I had a first cousin. Her name was Linda Creed. She was a singer-songwriter in the 1970s and 1980s, wrote all the music for the Spinners, and the stylistics was beautiful, brilliant, larger than life, the queen of Motown sound in Philadelphia, lit up every room she walked into.
Yeah.
She was my hero. She wrote 54 hits in all, and her most famous song was that iconic hit released by Whitney Houston called The Greatest Love of All. So Whitney released that song in March of 1986, and at that time it would spend 14 weeks at the top of the charts. Only my cousin Linda would never know, because Linda died of metastatic breast cancer just 1 month after Whitney released that song. I was 16 years old, and my hero died. Her life, and ultimately her death, gives birth to my life's purpose, because I never want another woman, another family, another community to have to suffer the way that mine suffered. And so I did the only thing I knew how to do. I became a doctor, the first doctor in my family. I became a surgeon. I became the first fellowship-trained breast surgeon in Philadelphia, the first oncoplastic surgeon in Pennsylvania. And I did that really well and for a really long time. And I did it long enough for my aunt to be diagnosed, and long enough for my mother. And then at 46, it was my turn to hear those words. And I went from arguably someone who was one of the most high-performing people that you ever knew to I couldn't walk across the room because I didn't have the breath in my body. And I undergo this intense 3-day workup. And at the end of those 3 days, I find myself sitting in the office of my friend and colleague and physician. And he tells me that I need surgery and chemo and radiation, and I'm going to be on lifelong medication. And despite the fact that these are things that I say all day without hesitation or reservation, despite the fact that I know that these things are standard of care because I myself am running a cancer program, when these words are coming at you, they are received far differently. And I can tell you that all the answers that I gave to women when they asked me, how did they get cancer? Why did they get cancer? And my answer was, oh, well, this is multifactorial and there's nothing that you could have done and you couldn't have prevented it or you can't change it. That answer, because of course that's the question that I'm asking now, that answer is totally unacceptable, totally insufficient, right? And as I'm sitting there trying to absorb this information, make sense of this information, all I can hear, and you can call it God, you can call it universe, whatever higher power you ascribe to, all I can hear in that time and space is there's something more, go find it. Now, I am a conventionally trained surgeon. I went to a conventional medical school, did a conventional residency, I'm running a conventional NIH accredited cancer program. There is nothing alternative, nothing integrative about me. I don't know anything about that world. I knew it existed, but I thought it existed for quacks and renegades, right? Not for the mainstream, right? So I have no idea what this calling is about. I have no idea what it's supposed to mean, but I can't unhear it, right? There's something more, go find it. So I go on a journey and I, in very short order, find myself sitting in a room, in a lecture hall, and this tall, lanky guy with this big toothy grin walks on the stage and he introduces himself as a functional medicine physician. Now, this is 2016. At this point, I am a doctor for 20 years, and all I can think of is, there's no such thing as a functional medicine physician. What is this quack talking about? And then I remember that I'm sick, and I'm there for a reason, so I check my big fat ego at the door, and I tune in. And thank God I did. Because on that day, not only would I learn exactly why I got sick so I could be in that room on that day listening to this man speak. Because these are our moments, right? These are our aha moments, our wake up moments, our moments of enlightenment, of discovery. And what I learned on that day was not only how I was going to heal myself, but how I was going to change my practice and shape my future and impact the world of breast cancer, which is not what I had, by the way. I had thyroid, so I just want to be clear. I don't want to put anything out there to the universe that's not in integrity. But I learned on that day that in the world of conventional medicine, we are completely focused on the wrong thing. We are entirely focused on the symptom. And we never for a moment think about why the symptom is there. And in the area of cancer, all of our focus is on the tumor. But the tumor is not the problem. The tumor is the symptom of the problem. And until we learn that, until we start to focus on why it's happening, we're not going to change anything. So I'm an early adopter. I get really excited about things. I'm a quick start. And so on that day, after hearing Mark Hyman speak, which in 2016 you can understand on some level, not knowing who he was. I had no idea who he was. Now it would be unimaginable to me to not know who Mark Hyman is. But in any event, after hearing him speak and talking about functional medicine and talking about root cause medicine and talking about actually creating health rather than just suppressing symptoms, I enroll in the Institute for Functional Medicine. I spend the next 3 years just immersed in the study of functional medicine, and I come out on the other side, and it's a bell I can't unring. And so I knew through that experience, through my own experience with illness, through my own experience with healing, which, thank God I did heal. It took years, but here I am, healthy and, as far as I know, disease-free. I knew that my role on this earth was to forever change the conversation around breast cancer, how we diagnose it, how we treat it, how we prevent it, how we screen for it. But I wasn't meant to help the thousands of women who I was operating on. I was meant to help millions and millions of people by changing these paradigms, these very, very broken paradigms, this dogma that we're living under, and change it for the better and make this world a better, safer place. And that's what I've done.
You know, I'll give it to you. That turnaround time from 16 now is really not that long. And to do all these things that you've done with, and we'll get into some of the screening processes that you're doing and everything, to just, it's like just went through the roof. And you look at all the screening areas across the country, and gosh, there's even one in Japan, I think. Is that right? But we'll talk about that later. Yeah. I'm getting ahead of myself. But so tell me the day that you decided to quit. You put this in your book. You kind of, you know, you was like, oh, that was my last day. That was it.
Yeah. This is not... So, you know, walking away from a surgical career, especially where I was in surgery, was not an easy decision, as you might imagine. I mean, if nothing else, I'm walking away from a big salary, a lot of prestige, a lot of security that my family, you know, we had made major life decisions based on the fact that I was a surgeon. Yeah. Right? Yeah. And so walking away from that was not easy. And I did, for a period of time, try to fit everything that I learned in functional medicine in the container of being a surgeon, because, you know, those people needed that too, right? So not only did they need surgery, but everything that we learn in functional medicine is the and that's what everyone needs. But, you know, I was trying to put 10 pounds of sugar in a 5-pound bag. I mean, it just didn't fit. And the hospital wasn't paying me to counsel people on what to eat and what to drink and how to move and how to think and how to detox. That's not what they were paying me to do. So here I am still in the office at 8 o'clock at night because I'm trying to fit 10 pounds of sugar in a 5-pound bag, right? So it didn't work.
Yeah, that's funny you mentioned that, because whenever I changed, so I was in the hospital as well, it really slowed me down because I so wanted to share more with my patients that I never did before. It's like, man, if you just listen to me, let's just spend a little time together and, you know, discuss some things in a little bit more depth. And it really slowed me down where I was spending a lot more time. Yeah. But yeah, go ahead.
My office wanted to kill me. I mean, they wanted to go home. And here I am, like, counseling people on what to eat and what not to eat, right? Yeah. So I'm in the office, I'm doing office hours, and it's right around the time when I have to decide to renew my contract. And I'm already back and forth with, you know, what am I doing here? Like, it so doesn't fit with what I now believe. Yeah. So I have this 19-year-old who's coming in because she has a lump in her breast. So she's not walking into my office. She's being wheeled into my office. So the exam room was about 30 feet from the elevator. And she has what's called primary progressive MS. Right. So 19 years old and cannot walk 30 feet from the elevator to my office. Okay, that's where her MS is right now. So I go in there, see her in the wheelchair, look at her chart, realize that she has MS. And just 1 week before that, I had met Terry Walls. Do you know Terry?
Yeah, I've met her.
Yeah. She, for those of you who don't know her, she's a Midwestern doctor who was diagnosed with primary progressive MS. And within like 2 years of diagnosis, had advanced to the part where she's in a zero gravity wheelchair, can't even hold up her own body weight, loses her, you know, gets let go by the hospital because she can't do her job. And this is someone who was, you know, in a university setting, had access to all the meds, all the protocols, all the treatments, all the everything. Right? And yet she gets worse and worse and worse. So she gets let go, and I don't even remember why. I mean, I did interview her years ago for my podcast, but I don't remember what the impetus was, but something about her, she was a lifelong vegetarian, but like a kind of like grain-based junk food vegetarian. Like as long as it didn't have an animal in it, she would eat it, but
Yeah.
it doesn't mean healthy, right? Like there are a lot of vegetarians and vegans out there who are just not eating healthy, and she was one of them. Right? So something in her says she needs to change the way that she eats. And she does. And lo and behold, she gets better. She adopts what I refer to as an anti-inflammatory diet. She gets rid of grains.
Right.
She's eating a lot of a variety of plants and clean sources of protein. She brings animals back into her diet. And lo and behold, her disease reverses to the point where she's now riding her bike 20 miles every day. Right? And this isn't over a long period of time. This is over months. So she goes back to the hospital and they're like, what the hell is going on? Right? And you got to write this up. You got to create a protocol and let's help other people. And she does. And then she writes her book, The Walls Protocol, and she helps thousands of people reverse their MS. Right? So I just met her. Met her the week before. And this woman rolls into my office with MS. I am so exciting.
Right.
I'm excited. I'm going on and on and on about the Walls Protocol, and you don't have to live your life like this, and I can help you. And after about a minute, this woman puts her hand up in my face and says, hey, doc, are you going to do my biopsy or not? Yeah. Not everyone wants my help. Not everyone wants to take responsibility for their health. Not everyone wants to own it. Some people just want the pill, the shot, the surgery, right? They don't want to take responsibility for their health. They want to put it on you. What are you going to do for me? And that's okay, right? No judgment. But that's not who I want to work with. These are not my people. And so I gave notice that day.
Yeah. Wow. Yeah, it's hard to unlearn some of this stuff whenever you go back and
we are very intentionally trained to be useful idiots. We are.
Yeah. Yeah.
We are.
Well,
I'm sorry.
Yeah.
We are.
Yeah.
And
just smart gorillas in one spot.
Yeah.
So that flipped and you put in your notice, which you're absolutely right. It is scary. It's like breaking out of the matrix. It's like a whole different, you're giving up a lot of security all of a sudden. So, and that's no joke, but you have to, sometimes you just got to do what you got to do. All right. Are you?
For sure. And it only took me 10 years to become an overnight success.
Just 10 years. So you start your practice. You obviously, I want to get into some of the screening stuff for how you view that. And I just listened to your last podcast. I think that's a great way to, you kind of laid that out because women come to me with questions all the time. Where do I start? What do I do? Do I just get a mammogram? Should I just do ultrasound?
Yeah.
And you lay it out pretty well there, but yeah, kind of go through that.
This is largely where the useful idiot part comes in because, we are all taught in medical school, in nursing school, in all these, conventional silos that we're trained in. Everyone thinks that mammograms save lives, right? This is what we're taught. And no one questions it. No one says let's look at the data because we just assume that the person that taught that to us did their due diligence. So we are taught that mammograms reduce your risk of dying of breast cancer by 20%. Is that what you were taught?
Yeah. Supposed to get a mammogram every year or whatever it was.
Do you know where that data came from?
Where? No.
All of the mammographic screening programs in all the world, in all the lands, came from an invitation to screen study done in the UK in the 1960s. And the person who spearheaded the trials is a Dr. Michael Baum. And if you get a chance to listen to him on YouTube talk about this, it is well worth I forget what his talk was. 40 minutes, 60 minutes, I don't remember. I can try to find the link to his talk. the one that I'm referring to and share it with you. So he talks about this study that looked at 1,000 women, and they screened them over 10 years. And when you take 1,000 women, and there were a whole bunch of problems with this study. First of all, the invitation to screen is going to go to people who are connected already in the system, going to the doctor, probably a little more health conscious, taking care of themselves. And it wasn't just an invitation to screen, it was who shows up. So who shows up to screen is going to be a little healthier, a little more health conscious, all of that. So there's no control for that variability at all. So that was one problem with the study. But what the study found is that if you screen a woman over 10 years with mammogram, 4 out of the 1,000 will die of breast cancer. If you don't screen women with mammogram, 5 out of the 1,000 will die of breast cancer. 4 is 20% less than 5. So mammogram reduces death from breast cancer by 20%. Let's open screening programs everywhere. That is literally what happened. Literally what happened. Now, what no one talks about from that study, which was there and plain as day, is that the same number of women die of cancer in both groups. There is no overall survival difference. None. Zero overall survival difference. So we did not save lives. We did not save lives. Right?
So this is just another poor interpretation of the study.
Yes, that's correct.
Yeah.
That's correct. It was a convenient interpretation for the study because what the study aimed to show was that mammograms save lives.
Yeah.
So that they could roll out these mammographic screening programs. And they did. Right? That's what they did. Now, what the study authors did not talk about and what the press did not pick up was that if you screen 1,000 women with mammogram, yes, you are going to pick up some cancers for sure, but you're also going to pick up a lot of things that aren't cancer. So you're going to cause around 100 women to have additional studies, biopsies that they don't need, overdiagnosis. You're going to find cancers that would have never presented themselves in a woman's lifetime, and overtreatment as a result. And that is what we have seen in the large-scale studies that came after this. So when you look at the Swedish trials, 600,000 women, this is universal health care, so everyone has the same access to care, everyone has the same kind of care, right? 300,000 get screened with mammogram, 300,000 just get physical examination. The same exact number of women die of breast cancer in each group. There's no difference. Right? So they did not find that you have a decreased risk of death from breast cancer. But this is what they did find. They found that if you screen using mammogram for breast cancer, you are going to diagnose 30% more breast cancers in the group that you are screening with mammogram. And these are the women who fall into the overdiagnosis bucket. Because these women would have never developed clinical disease in their lifetime. They would have died with breast cancer, not of breast cancer. But the second you diagnose them, you make them into breast cancer patients, subject them to breast cancer treatment. And breast cancer treatment is not benign.
Right.
When we treat a woman for breast cancer, not only are we changing the quality of her life, and we're diminishing it significantly, but we are also likely changing, I shouldn't say likely, we are lowering the duration of her life. And it's not because she's dying of breast cancer. It's because we're accelerating cardiac disease, cardiovascular disease, cardiomyopathies, neurodegenerative disease, osteoporosis. I mean, we can't forget about statistics like the same number of women that die of breast cancer every year also die of a complication of a fracture. So if we're causing osteoporosis by our treatments for breast cancer, have we helped that woman? If we're causing cardiovascular disease by the treatments for breast cancer, are we really helping? What is our overall gain? And the overall gain is nothing. There is no positive overall gain from screening with mammogram. And if you try to silo it and say, well, maybe if we take all comers, it's not helping, but maybe young women benefit because, you're going to pick up their breast cancer earlier, they have more aggressive breast cancer, so maybe screening them makes sense. Then let's look at the Canadian breast cancer screening study, which was women from the age of 40 to 59. Again, universal health care, so everyone gets the same access to care, everyone gets the same kind of care, and the same exact results from the Swedish trial are reproduced in the Canadian trial. And that's that the same number of women die of breast cancer in each group. And the only difference between them is that if you screen using mammogram, you are going to increase the number of women diagnosed with breast cancer by somewhere around 23-24%. But you are not saving lives. You are not. You are not saving lives. The same number of women die of breast cancer. How they manipulate the statistic is the more mammograms we do, the more diagnoses we make, you're just increasing the denominator, right? But the number of women that die of breast cancer every year has been steady for 20 years. We are not changing the bottom line for these women. And what mammogram is good at is diagnosing cancers that do not kill women, right? And so it's making an impact on how many people we're diagnosing, but it is not making an impact on how many women are dying of breast cancer. So when you look at the absolute numbers, there's no positive impact. And I don't think that we can dismiss the radiation-induced cancers because the statistic is you will save 1 in 10,000 by screening with mammogram, but you will also induce at least 1 woman in 10,000 with a breast cancer. So the net effect is there's a zero net gain. There's a zero net gain. And then you have all of the overdiagnosis and overtreatment. That's one side of it for me, and that alone is enough for me to say, absolutely no to screening mammograms. To screening, there is absolutely no benefit. The other side of the argument that people who support mammogram makes, they say that they save lives and they say that they save breasts. So let's look at that, right? Since you can look at the tables, the charts, and you can tell exactly when we started to increase mammographic screening. And the thought behind it was that if we're finding smaller tumors, because we're using mammogram to screen rather than physical examination, then women should be getting less treatment, right? Less surgical treatment, less medical treatment. So look at the mastectomy rate and what has happened as we increase mammograms. What has happened with the mastectomy rate is it's increased, and it's increased by 20%. So we're not saving lives and we're not saving breasts. And at this point, it is all dogma because there is no data to support screening mammograms. It doesn't exist. And anyone who tells you differently is either so stuck in the dogma that they can't see the truth, or they don't know how to read the studies.
So in your book, you talk about mammograms as, in the right setting, they're reasonable if you've found, if you've got a diagnosis that you're moving forward on to get a mammogram for that purpose, but not for screening and for the reasons you just said. You do a good job. I'd like to hear your path of how you look at screening for somebody, say a woman in their 40s, absolutely. What the flow is on that, how that looks like.
So I first want to say that my my blanket statement of no one should be getting screening mammograms does not say no one should be screening for breast cancer.
Right.
I am not saying that in any way, shape, or form. I want to be very clear about that. There are 100% safe and effective ways to screen for breast cancer that do not involve a mammogram, because mammograms are not safe. Any way that you look at it, this is exposing the breast to radiation. Radiation is a known carcinogen. I'm not saying this because I have anything against mammogram. This isn't a personal vendetta for me. I'm not trying to get at the system or get at the man or, it's not about that. It's about this world being a safer place, right? It's about not putting healthy women in harm's way. So, how do I screen for breast cancer? Because I do think that we should be screening for breast cancer, right? I think it's part of health. I also think that everything that we use for screening should also lead to or have the opportunity for prevention. And there is nothing preventative about mammogram. There's nothing preventative about ultrasound. There's nothing preventative about MRI, because these are at best early diagnostic tools, but they have nothing to do with prevention, right? So this is what I recommend for screening. I recommend self-breast examination. Again, it's not about prevention, but I do think that it's important to know what your body feels like when it's normal so that you can recognize when it's abnormal. And I have just known too many young women who have had normal imaging, and the only reason that their cancer was picked up was because they felt it on self-examination.
Right.
I know that the United States Preventative Task Force does not recommend self-breast examination. Don't even think the American Cancer Society recommends self-examination. And I had Michael Greger on my podcast recently, who also doesn't recommend self-examination. Now, I think it's bad form to argue with your podcast guest, but I do not agree with him there.
Why would you not recommend that? It seems like such
Because they
low-hanging
think
fruit.
that you find things and then your doctor doesn't know what they are, and so it leads to more biopsies for benign disease, and that is more anxiety provoking and expensive and blah, 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 blah. I think we just need to do a better job of educating the doctors and the providers, right, to know what is and what is not important. And maybe, get a little more skill in their hands, get an ultrasound in their hands to be able to recognize this is normal tissue or this is nothing. So I think that if we would actually teach people how to do examinations, teach providers how to do examinations, it will not be so anxiety provoking. But the other side of it is that if you know your breasts and you know what they feel like, you will know when something's wrong and different. So I think if we would do a better job of educating and do a better job of supporting, it would not be so anxiety provoking. So in any event, I do recommend breast examination. The next thing that I recommend for everyone is something called the ARIA test, the tears test. I don't know if you've heard of it or if you maybe just recently learned of it from listening to my podcast. This is an at-home breast cancer screening tool. I'm going to use that a little loosely right now, and you'll see why later. So what this test is screening for are two inflammatory proteins, the S100A8 and S100A9 proteins that are found in your tears. Now, it's a fascinating story if you'll humor me and allow me to tell you why we know that they're in your tear. Yeah. Okay. So there was a very, very famous breast surgeon named Dr. Susan Love. I don't know if you've ever heard of her. She was kind of the foremost authority in breast cancer in the 1990s, 2000s, and a lot of her work was centered around ductal fluid, breast fluid, and ductal lavage. So what she would do is lavage the breast through the ducts in the nipple, collect that fluid, and analyze it for markers. And she was hoping to create a test that would find breast cancer cells in their infancy and be able to do something in order to prevent progression to frank, overt breast cancer. Mm-hmm. So she has a huge database and she learns so much. But the bottom line is that who is going for a ductal breast lavage every year? Like, it's just not happening. Who wants to do that?
Were these women who had known cancer or concern
No.
thereof, or she was just doing ductal lavage?
Okay. Her goal was to find a screening tool for breast cancer that wasn't the mammogram, because she agreed that the mammogram was not a good way to screen for breast cancer. So she studied women with breast cancer. She studied women without breast cancer. She had a huge database. And she did find these proteins that were present in breast fluid that were highly, highly associated with the early stages of breast cancer. But this is not a test that you can roll out. Like, first of all, who's doing that at home? And who's going to go to their doctor every year for a breast lavage? I mean, it's just not feasible. So that didn't work out. But another breast surgeon said, well, her name is Suzanne Klimberg. She said, well, the process of making tears is very similar to the process of making breast fluid. Let's just check tears and see if that is a source, if we can reliably use that as a source. And as it turns out, you can. So, clinical trial, women, age 30 to 83, and they check the tears and they compare it to mammogram to determine, can we use this as a screening for breast cancer? And the answer is yes. As it turns out, it has a 92% sensitivity for breast cancer, way better than a mammogram, which is, all comers somewhere in the 70s or 80s tops, right? 92% sensitivity for breast cancer and a 58% specificity. Now, what sensitivity means is that if you have the disease, the test picks up the disease. What specificity means is that if you don't have the disease, the test reliably says you're negative. So 58% of the time that's true. 42% of the time, that person does not have clinical evidence of breast cancer, but the test is positive. Now, I want to start off by saying that there are no false positives on this test because it is not measuring for breast cancer. It's measuring for inflammation, the inflammatory precursors. And this is one of those times where you either have it or you don't. So if you have the inflammatory precursors to breast cancer, you are at risk. You are at risk. And this is opportunity. This is an opportunity to prevent a breast cancer diagnosis. This is prevention. We don't have anything else like this. This is prevention, and this test will forever change how we screen for breast cancer. This test is what everyone should be doing. Everyone.
So these women, just to kind of go through this again, whenever they were studying it and they found that it was in the tears as well, they also found it in the same woman in the ductal massage as being correlated to that cancer. Is that correct?
Yes. So they originally,
and again, a really good marker for. Go ahead. I'm interrupting you. Go ahead.
No. They originally determined that these inflammatory markers were highly correlated with breast cancer. And then it was like, what else can we source? Because lavaging the breast is not a realistic collection paradigm. So what other source can we use? And tears turned out to be the source.
Sure. And again, like you said, sensitivity being high is a marker for an excellent screening test.
Yes.
And if you go on and you don't find one, I mean, we know that bathing the cells in inflammation is just kind of a setup for cancer to happen in the future. So it really gives you some insight.
Yes.
So, and it's just from an eye test, from tears. You're getting tear ducts.
It takes 5 minutes. That's so easy. I mean, I'm just gonna show you what is involved because it's just easy peasy. It's a tiny little. Oh, did I throw it out? I might have thrown it out because I did a demonstration. But it's a tiny little strip of paper. It's the same. It's the same way that you do a dry eye test. So it's a tiny piece of paper. You fold out down a corner. You put it in your eye. Close your eye for 5 minutes. Take it out. Send it off to the company. And a week and a half later, you get your result. So it's really amazing. And if you have a negative ARIA test and a normal examination, the likelihood is that you don't have breast cancer. And it's not a genetic test. So this isn't something that you're doing once. You're doing this every year.
Yeah.
This is your breast cancer screening. And I do want to say that, that sensitivity, that 92% sensitivity, one of the major reasons why it's not higher is because we're using mammogram as the comparison. So mammogram has like a 70 or 80 some percent sensitivity. So mammogram isn't picking it up either. So there are going to be some people that have a clinically positive ARIA test that have a mammogram and it's negative, so that then it is called a false positive. But the truth is that they do have breast cancer. It's just we used a lousy tool to identify whether or not they had breast cancer. So if you have a clinically positive ARIA test, there is something there. You do have the inflammatory precursors. You do need to work on your inflammation. And I am launching JennSimmonsMD.com in 2026. And there will be a prevention program for all of these people that have a positive ARIA test. Now, I do want to talk about imaging because we have been very conditioned to do imaging, and I think imaging is necessary, but I do not think that we should ever be putting ourselves in harm's way for the purposes of screening. Ever. So I only believe in safe screening. And about 2 or 3 years ago, I was introduced to a technology called QT, which will revolutionize, which is revolutionizing, which has revolutionized how we screen for breast cancer.
Yeah, say more on that. I want to hear all about the QT thing.
I opened the first center. The first freestanding center utilizing this technology in August of 2024. So this is sound wave technology. It's circumferential sound wave technology. It's transmitted through a warm water bath that collects 200,000 times more data points than MRI and creates a true 3D reconstruction of your breast without pain, without compression, without radiation. So in what is a 20-minute spa treatment for your breast, because essentially that's what it feels like, you get a true 3D reconstruction of your breast. Is it perfect? No. It has a 91% sensitivity for breast cancer, so better than any other imaging modality other than MRI, without the false positives, because MRI is notorious for false positives. And MRI requires gadolinium. This is a heavy metal. It was not meant to be put in our body. It is a toxin. It has, not only does it have environmental impacts in our body, it has environmental impacts because we're urinating it out, we're disposing of it, and it is affecting our groundwater, our soil, our everything, right? So I do not use MRI for breast cancer screening for a host of reasons. The gadolinium, the overdiagnosis. I've just seen too many women have unnecessary biopsies, unnecessary surgeries, and surgeries that forever change them. I've seen women have their breasts removed because of an MRI that said that they had diffuse cancer in their breast with nothing on pathology. Nothing. Yeah. It's really scary. It's really disturbing.
So the QT, a woman will go sit in warm water? It's like
her breast. Just her breast is submerged. So she's lying on her stomach and there's a hole in the table and there's a tank of warm water that rises to meet her and she just lies there. The lights are down. Lovely music is on. And it's a beautiful experience, unlike anything they've ever experienced before. It doesn't feel clinical. It feels like a spa visit. In what feels like a spa visit for your breast, you are screened for breast cancer. Now, I use all the modalities. So I am having everyone's getting an exam by my tech who is trained by me, who knows how to examine breasts. And let me tell you something. She is right nearly 100% of the time. She will write on the list, tissue feels prominent here, but it's just breast tissue. This feels like a cyst. This is going to be a solid mass. And by golly, she is right. It's amazing. It's amazing.
Yeah. A good valuable tech is worth worth every cent. Yeah.
It absolutely is. And, that's part of why people come to Perfection, because they know that they're trained by me. They know that it's not a visit with me. So I don't want to create any undue expectation. Yes, I own that center, but this is not a doctor-patient relationship. They're not seeing me. Sometimes they get to see me because I'm there. What they're getting is this experience that is highly, highly curated by me with intention, because I am absolutely hell-bent on making breast cancer screening painless, atraumatic, respectful. I want to honor the woman that wants to honor herself and her health, and I would never put her in harm's way for the purposes of screening. And with an exam and the ARIA test and the QT scan, like what we do at Perfection, that's exactly what I've created. And let me tell you, I feel great about it.
You should.
I feel great about it.
How many of these centers are there?
So I have one center in the suburbs of Philadelphia. I am probably opening up somewhere between 4 to 6 more in 2026, and I intend on opening up 50 in 5 years. There are a few other centers. There are more to come. The more I talk about it, the more people want to adopt this. Do I think that my center is doing something special beyond what everyone else is doing? Yes, absolutely. But I believe in the technology. I believe that this is the imaging of the future. And if you don't have access to it now, I'm going to make sure that you have access to it, because I want everyone who wants to screen this way, who wants to screen safely, atraumatically, and with honor and respect, to be able to do it.
So I want to go back over. So if you've got somebody that's in their 40s, they want to screen for breast cancer, the easiest way is start with the ARIA test. Shows up at your house, you do a tier thing, you collect it, you send it off, within a week or two if it's something you need to pay attention to. If it is up, you got to pay attention to inflammation and go down that route either way. But then moving on towards further evaluation, and the way you do that next would be,
if you have a clinically positive result, you need imaging. And obviously, I recommend QT for imaging. And I think we should probably talk about the wisdom trial because everyone needs to be thinking in this way. Have you seen the results of the wisdom trial?
Did you talk about this in your book? This wasn't in your book, was it? Or was it?
No, because I think it was just presented in San Antonio in December.
No,
So
bring me up
this
to
is a
speed.
mammogram study, and it looked at whether or not we should be just recommending mammogram across the board to everyone every year, which is what we've been doing, and we've been doing that for like the past 4 or 5 decades. Or should we be thoughtfully considering who is getting mammogram and who is not? And the answer to that is yes. Now, do I wish that there were a no mammogram arm of that study? Because you know that I don't believe that there is any benefit at all to screening mammogram.
Right.
There wasn't. But let's talk about what they did learn, because they learned an important lesson. And that's that they divided the groups up into one group gets a risk stratification and the other group just gets screening mammogram every year. And in the group that gets a risk stratification, there is a low risk group, an intermediate or an average risk group, and a high risk group. Now, the low risk group is not getting screened at all until they're 50. And then after 50, they're getting screened like maybe every other year with mammogram. Intermediate or average risk group is getting yearly mammogram, and the high risk group is getting yearly mammogram, yearly MRI, spaced 6 months apart from one another. So they're getting screened every 6 months.
How are they calculating their risk? Was it just
They're using a combination of genetics, Tyrer-Cuzick. They have a risk calculator that they're using to determine. And so what do they find? Well, they find the same number of breast cancers in each group. So, wait, is that true?
they found the same number in the ones they screened and the ones they in the risk stratification group and the screening mammogram group?
Wait, I have to remember all the statistics now.
Okay.
But the end point was finding stage 2 cancers. That's what they were primarily concerned with. And they found less stage 2 cancers in the group that they used the risk stratification, right? So less stage 2 cancers than in the group where they just screened everyone. However, they found more stage 1 cancers, so more early cancers that probably wouldn't have had any long-term effect. And they did way more biopsies in the stratified group because they did more MRIs. So the more MRIs you do, the more biopsies you're going to do, but the number of cancers in each group is the same. So the distribution is a little different, but the number of cancers in each group is the same. And what this tells us is that there is no benefit to yearly screening. It is not one size fits all. And the only people that really need to be screened with mammogram are the ones that are at increased risk, because you don't get any benefit from screening the low risk people or the average risk people. And it's only the high risk people that have any benefit from mammographic screening.
So in the risk stratification arm, the ones that were high, the way they evaluated them was with mammogram or mammogram and MRI?
And MRI.
Okay, both of
And
them.
MRI. But there's no overall benefit demonstrated. No overall benefit. So if there's no overall benefit, we can take away from that, not everyone benefits from screening.
Yeah.
Right? And it's only a select group of people that need to be screened. So what I am doing with that information is I've already done that. I've already been there, because my way of determining who does and who does not need imaging is the ARIA test, right? Like that's how I know who does and who doesn't need screening. right? And this is a real-time biologic assessment of, do you have the inflammatory precursors to breast cancer?
Yeah.
Do you have?
So it's not only screening, like you said, but it's preventative. I think that's worth
It's
kind of double
preventative.
tapping.
And it's the only thing that we currently have that can be preventative. It is.
Yeah.
So, that genetic testing that everyone is doing and jumping on the bandwagon, that is the only thing that does is tell you if you have a genetic predisposition, but your genes aren't the thing. The thing is the environment. It's what are your genes existing in? And for that, sorry, my dog is yelling at me.
What kind of dog? There it is.
This is my toy poodle who was sick of being ignored.
By the way, I love the story of your mom and the dog in Vegas.
Oh my
At the beginning of the
God.
book. That was hilarious.
My mom is such a trip.
Yeah.
She is such a trip. Yeah. Well, I really wanted my book, The Smart Woman's Guide to Breast Cancer. I mean, I wrote it so that women could make informed decisions, so that they could make informed decisions around whether or not to get a mammogram, whether or not to get an MRI, whether or not to undergo certain treatments for breast cancer, how to make decisions about your diagnosis, about how you're treated.
Yeah.
I need women to make informed decisions because they're not able to do that now. Because in order to make informed decisions, you have to have information. And they're not getting it. They're not getting it. And so it was really important to me to put something out there that was easy to consume, enjoyable to consume, made sense, feels good, empowering, hopeful. That's what I did.
Yeah. Yeah. Well, you succeeded. I don't know when it came out, but I enjoyed it. Like you said, this inflammation thing, I'm going to share another that just came to mind. I remember seeing a woman in the hospital, young, had breast cancer, moving along pretty well. I don't remember what the stage was, but I asked her what she had for breakfast, and she said, I had 2 donuts. And I thought, oh my gosh, that just hurts me. But anyway, my screen froze, so we'll have to edit this part out, I guess. Hey.
Hi.
I'm sorry. I don't know what happened. It just kind of...
I don't know either. Just so you know, for your producer, I think we went out at an hour and 1 minute and 57 seconds, maybe.
Okay. All right. And I just shared a dumb story about the breast cancer girl with the donuts that just killed me. But
I know. So you were saying...
But yeah.
Speaking of inflammation, I remember seeing a woman in the hospital. So do you want to just pick that up again?
Yeah. Speaking of inflammation, though, that we talked about. Yeah. Speaking of inflammation, I just remember all the time, and my scribes would be with me, and I was in the emergency department was my thing, and I had a few of them that would every time I'd ask them, so what did you eat over the last 24 hours? They got so sick of this question. But I remember hearing that all the time. And I saw one girl who was in her 40s with pretty advanced breast cancer and getting treatment. And I asked her what she had in the morning. And all she had was 2 donuts. And that was it. And a Coke. And I was just hurt. I was like, just don't. Please don't.
It's painful.
But
unfortunately, women getting breast cancer treatment are getting their nutrition advice from medical oncologists who have zero knowledge in the area of nutrition. And they're taught that no matter what you do, don't lose weight, because they associate weight loss with cachexia, which is, a very end stage symptom of cancer. So they're applying something that doesn't apply in this situation, which, listen, lots of breast cancer patients are malnourished, right? But eating pizza and ice cream is not solving that problem for them.
Right. It's not.
The calories and the kind of calories, as you well know, I mean, I'm preaching to the choir here, but the kind of calories that you eat really matters. And quite frankly, I have my women who are going through chemotherapy for breast cancer, I have them fasting because we know from the work of Walter Longo at USC that if you fast while you are getting chemotherapy, you will actually create an environment that protects normal cells and makes the cancer cells more vulnerable. So you'll have better response to treatment, but less side effect, no less negative side effect. You'll require less supportive drugs. You'll require less blood products and blood product support. And yet, this should be happening at every medical oncology center in the country, let alone the world, but it's not, because we still are practicing in silos. And, like, that's not my space. I'm not going to worry about that. It's terrible.
So I'm going to ask you a few questions, and I've kept you long enough, and I really appreciate this. This is awesome. I really appreciate picking your brain. And again, I can't recommend your book well enough for anybody who isn't
The
human.
Smart Woman's Guide to Breast Cancer for anyone who's looking for it.
I'll give you all the shameless plugs because I think it's worthwhile. But I'm going to ask you some questions, and you're going to fire away. So, and you know these. We've probably already talked about some of these, but what's the one thing women should stop doing today if they truly want to reduce their breast cancer risk? What would be some of the top 2 or 3?
Yeah, so the number one thing that we can do today that would decrease the amount of breast cancer in this country by 20 to 30% is stop screening with mammogram. The more mammograms you have in your life, the higher your risk is of being diagnosed with breast cancer, right? The more mammograms you have in your life, the higher your risk is of being diagnosed with breast cancer. That is both because mammograms use radiation and they are eventually going to be responsible for causing some of the breast cancer. And mammograms are notorious for starting that path to overdiagnosis. So these are cancers that would have never been diagnosed but for the fact that you're screening with mammogram.
Why don't women hear this more often?
Because they're indoctrinated in the dogma. They're told that mammograms save lives and they believe it, right? And there are so many women out there that say, I had my first mammogram at 50 and it picked up my cancer and mammogram saved my life.
Yeah.
Or better yet, I love the ones that are like, I felt a mass on my breast and I had a mammogram and it diagnosed my cancer and it saved my life. No, it didn't save your life. Mammogram didn't save anyone's life ever. Right? Like your doctor might have helped, what you did might have helped, but radiating your breast with a mammogram did not save anyone's life ever. Like, let's not give it credit it's not due.
Yeah.
But it's dogma. And you know, it's hard to untangle this. We have been so programmed to believe that mammogram has a positive influence, that makes a positive contribution. It does not. There is nothing positive about it. It is not doing anything to help anyone. It's not. It has a net negative gain.
Yeah.
Because even if you cancel out like save one life but cause one cancer, like even if that cancels out, you still have to deal with the fact that it leads to unnecessary imaging, unnecessary biopsies, overdiagnosis, and overtreatment. And the price that we pay in those silos is way too high and completely negates any kind of benefit that it would ever have had. That is the number one thing we can all do tomorrow is stop screening with mammogram. Now, does that mean that you'll never have another mammogram again? No. Because as much as I would love to say like QT is going to take over everything, right now QT does not have biopsy capability and you need to specially train to read QT. These are read by radiologists, but they're read by radiologists who are specialty trained to read QT. Just knowing how to read a mammogram, knowing how to read an ultrasound, knowing how to read an MRI does not mean that you know how to read QT. It's not a logical progression. It requires specialty training. So right now, the breast surgeons are not trained and they're not going to help you unless you speak their language. And their language is mammogram, is ultrasound, is MRI. So if we find what we believe is a cancer on QT, we have to send you for those studies because you have to speak the language of the breast surgeons, the breast specialists. So I'm not saying that no one will ever have another mammogram again. We have not sunset that program, and I'm not throwing the baby out with the bathwater.
Sure.
I am saying that no one needs a screening mammogram ever again. Do we need it for diagnostics? Yeah, we do right now. Do I think that we're going to be having a very different conversation in 5 years?
Yeah. Yeah.
100%. We're going to sunset that program. Mm-hmm. We are going to sunset that program. It's not now, but is coming.
Yeah. So that brings me, before I let you go, what is next for that you're most excited about? You've already talked about it some, but what's next for Dr. Jenn Simmons? What's going on?
Yeah.
What are you
So
into?
JennSimmonsMD.com launches tomorrow. It launches tomorrow. Yeah.
Happy New Year.
Yeah. I'm so excited. We're in beta testing today. And so it launches tomorrow. And I couldn't be more proud of what we've built.
Right.
And, you know, for so many years, I was trying to figure out, you know, how do I help millions of people? Right? Because that's my goal. That's my goal. And obviously, everyone wants to work with me, and I get it. And I do want to help people on an individual basis, but my bandwidth to do so is extremely limited. And as I am out there opening perfection imagings and wellness, because that's what we're shifting, everything has become perfection imaging and wellness, because I realize that there is a significantly underserved population, and that is the woman who has had breast cancer. And I make a huge distinction between having breast cancer and had breast cancer, because the woman who had breast cancer is not getting help, and she needs it. She is the forgotten woman. And while everyone else is out there talking about menopausal care, talking about bioidentical hormone replacement, these women are still being left out of the conversation, even by people in the know, even by people who understand that estrogen doesn't cause breast cancer, that women who take hormones after breast cancer have survival benefits, because everyone is worried about being supported by their society. They're worried about their medical license, their professional license. And I get it. But it's time to come out of the shadows. It's time to speak the truth. It's time to show the world that we've been doing it. We've been doing it on the down low, and we know it's safe. And do we have huge studies to show? No, we don't. And we'll never have huge studies to show, because
they're not going to
you
do it.
can't trademark a molecule of nature. So who's paying for that study?
Yeah.
No one's paying $1 billion to do that study. It's not happening.
Yeah.
And yet there are people out there with decades and decades and decades of experience who have been in the trenches, who know, who see the beauty of doing all of this. And all I'm doing is championing it. So I have changed my perfection imaging to perfection imaging and wellness, where we are screening for breast cancer using the most technological and safe and innovative methods. And we are helping everyone who wants to achieve prevention, optimal health, recovery, restoration, all of that. And we are not ignoring this population of women who had breast cancer. They are suffering, and they are suffering unnecessarily, and I'm going to make sure that they're not. So we are at the same time where I'm rolling out all these perfection imaging and wellnesses, I am now creating a platform so that I can help women without having to one-on-one help them. And that's going to be at JennSimmonsMD.com. And everyone's going to start with a 3-day experience. That's what we're launching. And then our foundations program, our prevention program, our advanced wellness program, our hormone program, it's all going to be there. It's all going to roll out. We're going to drip it out in 2026. And that is what I am so excited about. And that is how I am changing the lives for millions of women.
You got there. You wrapped it up. I can tell. I really can't thank you enough for all the time I've kept you over. And you've got a lot on your plate because this thing thing is launching tomorrow. I knew you were doing it, but I didn't know it was launching tomorrow. So that's awesome. And the book, and this is going to be some great content for women. And I'm excited about where it's all going. And this Aura test is pretty awesome, and just, the whole deal. So you're really changing the face of dealing with breast cancer. So I appreciate the work you're doing.
Absolutely.
I mean, it's great. Yeah.
My pleasure. My pleasure. So for people who want that ARIA test, it's aria.care, AURIA.care, and you can use the code Dr. Jenn 20, DRJENN 20.
Okay. And outside of the website and everything, how do people find you, follow your content, and
Yeah,
all
absolutely. So perfectionimaging.com is PERFEQTION, imaging.com, and JennSimmonsMD.com, and Jenn is spelled with 2 N's. And you can find me on all the social channels. So Instagram and Facebook and Twitter and YouTube. Well, it's not Twitter anymore. It's X or whatever.
Yeah.
YouTube.
Yeah.
I'm at Dr. Jenn Simmons, and my Jenn has 2 N's.
Cool. Well, thanks a lot. And yeah, thanks everyone for listening. And as always, stay curious, and we'll see you next time. Thanks a lot. Bye-bye.
Bye for now.